And we're mostly going to do contraception, and we'll do a little bit at the end if we get to it. You can go through the objectives on your own. So there's a ton of different contraceptive methods. This is approved by the US. A lot of this information came from the World Health Organization. IUDs are more and more common. Progesterone-only contraceptives, we will talk about individually, as well as combined hormonal contraceptives, also called COCs, or combined oral contraceptives. However, not all of them are oral. There's emergency contraceptive, which we will talk about briefly as well. Barrier, and then fertility awareness, which we'll touch on. And then lactational amenorrhea period, we will talk about, as well as the rest here. So I liked this because it had some pictures, and I feel like it was helpful to understand where things happened. And I like that it's, your reversible, and then what's reversible, and then here's your permanent sterilization over here in the blue, and kind of what they're doing with a female. Quite literally, they cut the tube from the fallopian tube from the ovary and on both sides to the uterus. Interestingly, that is slightly less effective than a progesterone IUD. However, male sterilization or a vasectomy is much more effective. And so that's a huge thing. Many men are not willing to have a vasectomy. It is something that's very scary to them. However, it is an outpatient office procedure. It's very easy to do. They do need follow-up afterwards, however, to make sure that there's a sperm count and that there's not. They look for, I think, under 5 sperm in a sample or something like that. All right, so I'm going to go ahead and move on and not discuss each of these. We will get into them. All right, so I wanted to share this slide because I thought this was really interesting and telling. So this is worldwide. This isn't just the US. There are different names and different types of contraceptives that are available worldwide that are not necessarily available in the United States. And some of them are cheaper and as efficacious, but it depends on what the US has allowed for. You can see that there's a good portion of people who do choose sterilization, females much more than men, as you can see. And then a lot of people are using IUDs. I wish I had data from prior to 2019. It's definitely not necessary, but the IUDs there was a flaw in the IUD that was causing issues. That IUD no longer exists. And so you will see a handful of people out there who have familiarity with this and don't want an IUD because they have fear that their grandma had it and got a bad infection or could never have kids or whatever. We don't use that IUD anymore. It was really a defect in the device itself. And it is very effective, and we'll talk about it. It's definitely by far my personal favorite type of contraception to use because it's very effective and very easy. A small number of folks use the implant. It's still quite common, but it depends. Interestingly, different places that I've worked, there's been different, and different populations have had different preferences for what they use. And then there's your injectables. I'm kind of surprised at the number of injectables, which is the Depo-Provera, and the implant, which is Nexplanon, are the same because the Depo-Provera tends to cause a lot of weight gain. And again, we'll get into the details of that a little bit more in a few minutes, but the Implanon is a much nicer medication overall, though still has its flaws. And here are the folks in the US that are still using the pill. It is quite a large number. Most of those are the combined oral contraceptive pill with both progesterone and estrogen. And then condoms are still very common. There are some people who use the rhythm method. Let there be no confusion that the rhythm method is way more effective than withdrawal, which a whole lot of folks are using withdrawal. People use withdrawal. One of the things that never ceases to amaze me is that folks who are in their, I will say, late late cycle or late phase, and they haven't hit menopause yet, but they might be 42 or 45 or 47, and they have no desire to have children, and you ask them what they're using, and usually it's withdrawal or nothing, I haven't gotten pregnant in years, or whatever. And until a woman is in menopause, she can get pregnant. The women, I feel like about once a year, I have a woman come in and she's pregnant. I will often also say that more often than not, there's a spontaneous abortion, or she miscarries, and so it doesn't turn into anything, but it would be really nice to prevent those issues. One of those, I had a patient with a molar pregnancy that was older, and it was a complication of her pregnancy. A molar pregnancy isn't actually a pregnancy, but a cancer. So anyway, I just want to give you some idea of when you're counseling people of where they are. And this is age 15 to 49, so a pretty good span of the population. You need to be familiar with these. There was a link in this week to go see the WHO. The WHO has this great contraceptive chart. It's kind of big, it's kind of ugly. Please, keep it in your virtual or real notebook, be able to read it, be familiar with it, know how to read it. This is very important. This is going to help you determine the risk categories. So this is category 1. It means there's no risk for the use of the contraceptive method. For a woman with that condition, you can use it. There's no concerns. And then number 2 is that there's advantage of using the method, but they generally outweigh the theoretical or proven risks that exist. And then the third category is theoretical or proven risks of the method usually outweigh the advantages, but it's not usually recommended unless there's not a more appropriate method. It's unavailable or unacceptable to the patient. This is when you use shared decision making with your patients to say, oh, this is really what I think we should use. For example, contraceptive pills in women over the age of 40, but that's not necessarily what they want to do, right? So we make that decision together. I want to make sure they're very aware of the risks before they do that. And number 4 is unacceptable health risk if the contraceptive method is used by that woman, by a woman with that condition. This is, do not do that. I don't care what they say to you. I don't care what the shared decision making is. If it's a really unacceptable risk, then you kind of have no ground to stand on if something bad happens. And it's unacceptable because the risk is very high. That said, please take all of this, I don't want to say with a grain of salt necessarily, but please understand that the risk of using hormones with women is the hormones that you're providing are very similar to the hormones in pregnancy. And so if a woman gets pregnant, they have very similar risk of using any of these methods, not any of them, but specifically the combined oral contraceptive, as they would if they got pregnant. And so it is not a decision that I would want to make personally, but I might refer them to someone else to discuss it further. All right, we're going to talk a little bit about the breast cancer, estrogen-dependent neoplasia, and the complicated valvular heart disease and diabetes vascular complications. And these are exposed women, not just, these are risks of unintended pregnancies as well. So there's a great portion of the pregnancies in the US that are unintended. I think the majority of pregnancies are unintended. I'm not saying they're not welcome, but it was not meant to, that was not expected. Oops. All right, so here's your category 1, no restrictions. So somebody is more than 3 weeks postpartum, or post-abortion, after they've had an abortion, performed in the first or second trimester. History of gestational diabetes, that's fine. Varicose veins, not a problem. Mild headaches or intermittent headaches, that's okay. Irregular vaginal bleeding, and without anemia. A past history of public inflammatory disease, that's usually secondary to sexually transmitted infection. And then a recent history of STD. So I please want you to know there's no restrictions, and these people with a current or recent history of pelvic inflammatory disease or current or recent history of a STD or STI. There's no restrictions with those folks. You do want to do some education for sure, but that doesn't mean that they can't have whatever kind of contraception they want. Same thing if they have a vaginitis without a purulent cervicitis, which is inflammation of the cervix. I just always remember that itis is just inflammation, usually meaning infection in those cases, but not always. And same thing, increased risks of having STIs if they're HIV positive or high risk for HIV infection, benign breast disease, a family history of breast cancer, endometrial or ovarian cancer, cervical ectropion, viral hepatitis carrier, uterine fibroids, past ectopic pregnancy, thyroid conditions. None of these say you have to use certain methods. Whereas category 2, our advantages of using contraception outweighs our risks. I don't want to spend too much time on this because I want to make sure we get to the kind of the meat of the lecture here, but I do want you to be familiar with these. And more than that, I want you to be familiar with the chart and how to use the chart. If you had to look somebody up, they have migraines. How do you look them up? They have undiagnosed vaginal uterine bleeding. What's your risk? Here's especially kind of, these are more important, your 3s and your 4s. If they're less than 21 days postpartum, if they're lactating. Interestingly, WHO now recognizes that there's no restrictions in using combined oral contraceptives with lactation. It used to be considered that you could use progesterone only. However, with progesterone only, it's not as effective. And so it's pretty high risk for pregnancy. All right, age over 35, a cigarette smoker, that puts you at much higher risk for some kind of thromboembolic event. History of breast cancer, but no recurrence in the last 5 years. Interacting drugs that affect the liver and gallbladder disease as well. And here are your really important ones. Uterine fibroids with cavity distortion. So we know that the uterine fibroids are inside of the uterus. Don't go and put an IUD in there. That's a bad idea. Somebody who has, we know they have thromboembolic mutations. You don't want to give them any kind of combined oral contraceptive or combined contraception because they are already at high risk of having an event. Having pelvic inflammatory disease, cervicitis, or active gonorrhea or chlamydia, you don't want to initiate putting an IUD in at that time. A lot of people, if you don't see signs of it, will place an IUD and do a screening on the same day. If you've done it and it turns out that they have gonorrhea or chlamydia, that's okay. You just treat it. But you're really looking for the symptoms of it. Pelvic inflammatory disease, you're going to notice their pelvis is going to be very tender. It's something that you can diagnose on exam. It's not something that you send out a lab for gonorrhea or chlamydia, because a lot of gonorrhea and chlamydia is asymptomatic.
So as soon as they're asymptomatic, you can put them on like a contraceptive?
Yeah, absolutely.
Okay.
Yes. And this is actually just specifically about IUDs. It's not about other contraceptives. If you think about somebody who has gonorrhea, chlamydia, just their risk for additional sexually transmitted infections is higher. And the likelihood of them getting pregnant then is also higher, right? That means they're not using any kind of barrier method. And if they're not using any kind of birth control at all, no barrier method or otherwise, then it's prudent to put them on something so they don't get pregnant. Conditions, high risk, HIV. So with high risk of HIV, you want to make sure people are using condoms. So it's not that they can't necessarily use other things, but you want to make sure they're using condoms because they are high risk for HIV. And I'm sorry, spermicide use is a category for this group. I was misunderstanding, excuse me. We already know that cerebrovascular coronary disease we don't want to go there. Migraines with aura or migraines over the age of 35, that also put you at higher risk for a thromboembolic event. Boy, oh boy, I think that this has changed and it wasn't up to date in this slide. I apologize because I just read this today that I was really happy that they allow for combined oral contraceptives now with lactation. So please disregard that one. Liver disease is a big problem due to the way that these are processed in the body. The hormones are processed in the body. But again, that's not going to be your IUD that causes issues. These are the ones you look up and you find out what is safe in this group. Headache with focal neurologic symptoms. That's going to cause issues if you have estrogen or combined oral contraceptives, TOCs on board. Same thing with major surgery, prolonged immobilization, over 35 years in smoking, hypertension, history of thromboembolism or major, I feel like that was just repeated. Okay, so I want you guys give me a quick do the thumbs up, thumbs down thing in your windows. A 16-year-old wants pills but refuses a pelvic exam. Do you give them to her? What do you think? Is this a yes or a no?
I don't say you do the no. I only get the thumbs up or clapping.
Okay. Anybody else? Okay. 19-year-old U of I sophomore says her menses comes on Sunday. She wants to know if she can start her pills this Sunday or next. Anybody know the answer to that?
I think it's next, isn't it?
Yeah, you start after.
For your period.
Okay. We're going to go over these questions again later too. To take a break from pills for 21-year-old stops her pills for a month while her partner is off visiting medical schools. How long a break does she need?
How long is the partner really going to be gone for?
Well, if he's really gone for a month, is that your answer? A month?
No.
How long of a break does she need to be off of it?
I feel like you have to use some kind of secondary barrier.
Why is that, Natalie?
Because it takes a little bit of time to be fully effective.
Correct. 16-year-old presents with her mother requesting pills for acne. The mother insists that you give her the ones that are the cheapest. The patient wants the ones that she sees on TV that are good for your skin. Which do you choose?
Talk about advantages and disadvantages.
Not all pills, because it's a hormone. It can affect people differently. Just because it says it fixes your acne doesn't mean it's going to.
Are pills indicated for acne at all?
No.
Okay. 23-year-old is getting ready for, getting her monthly premenstrual dysphoria disorder. What do you advise?
She could start a SSRI the week of her period. I know that's one treatment option for PMDD.
Mm-hmm. Anybody else? Okay, 55-year-old comes in on birth controls from her prior physician. Is this dangerous?
Yes.
Absolutely. 26-year-old with 3 previous, I don't know what ME is. Sorry. Presents for contraceptive advice. She has a sister and a mom with breast cancer. And she refuses to take the pills. She refuses to take pills. Hold on.
Is it miscarriage?
Maybe? I don't know.
Or
It's usually SAB is a miscarriage. I almost want to say MI, but I don't know what that is. Anyway, with her sisters having breast cancer, can she take pills? Her sister and mom having breast cancer.
Depends. I thought it was depending on the type of breast cancer, and you can use them, some types of contraceptives
That
as
first,
long as the hormones.
What, Kelsey?
that first slide you showed us said yes, that she can take them.
So when we're giving someone contraception, we want to give the safest, the best tolerated, and the most effective method that the patient wants. So when somebody wants something, are they going to do what it takes to use it? Usually, yes. When someone is 14, 15, 16, are they good at taking something at the same time every day? No, absolutely not. And so you want to work with them and help them, all the options. There's, I forget who has it. I think it is the CDC has a great handout. It's kind of similar to that first slide I had for you, that shows all the different kinds, all the different options. And then most states also have handouts that talk a little bit about each type of contraception and what they can use. Because we did not have patho yet, that's coming next week. I just wanted to give a really brief overview. Our oral contraceptives, they're really going to work at the ovary. They're going to prevent the release of an egg. Please know that the progesterone only pills, they need to be taken at the same time every day, very consistently to prevent pregnancy. They're still not awesome. They prevent ovulation about 50% of the time. So not awesome. IUDs, most of you know, I think, hang out right here in the uterus. It's quote sterile technique, which unless you're in surgery, there's not much sterile technique. It just means really, really clean. But it goes through the cervix. So through this os and through this os or muscle into the uterus, which is uncomfortable, but typically does not come out. It can, especially women who have had many children and the birth canal is open more, or the cervical canal here, it can come out. It is a possibility, but is unlikely. And of course, we know condoms or other barrier devices, condoms, caps, cervical caps, or diaphragms, they work outside. Just to kind of slide looking at everything. Okay, so this just talks about, and I apologize, some of my slides, I got all excited about putting them all in here, and then I got mixed up on my location of them. I think that this is because it's right before the estrogen information, but this is your body's natural cycle. And so, this is your normal level of progesterone. And then when you're taking pills, there's pills they're monophasic. And then there's multiphasic. So data shows that there's no real big difference with taking monophasic versus the multiphasic. And so I usually stick just with the monophasic, and with the concept that the lower dose is better if they can tolerate that okay. Sometimes you find if people are having breakthrough bleeding, this might be more helpful, but I believe data has not shown that to be the case. I'm definitely out of order because my estrogen should have been first. Okay, so first thing I have down here is no hormones. The Paragard IUD, which I don't have a picture of, but it's a copper IUD. The copper makes a hostile environment in the uterus for the egg, usually, and the sperm. So usually the sperm don't get past there because it's a hostile environment for the sperm, so they can't live through that. It is a possibility. There's a very, very small possibility, but for people who really feel strongly about making sure that, they're very pro-life and don't want to ever have, cause any kind of damage or problem, there's a very small chance that there could be a union of this egg and sperm, but when it goes to implant, because of the hostile environment, it can't implant. And so if someone feels very, very strongly about that, I don't give them this kind of a Paragard IUD. It just is not gonna, it's not gonna fly, right? That's not what they want. And like we were talking about, we want to make sure we're using the best thing. And I want to make sure, even though if I say, oh gosh, this is really the one for my patient, if she finds out somewhere else that I lied to her and didn't tell her the whole truth, then we have just ruined our relationship. And so I want to make sure that she understands the whole truth. Paragard can also be used for emergency contraception. So because it causes that hostile environment and can help prevent the implantation, you can use it as emergency contraceptive. I'm sorry, I can't think off the top of my head. I think it's 72 hours after you can insert after intercourse to prevent pregnancy. However, you need to know that Paragard can cause a heavy menses. So you take someone who has spotting all the time already, or they have a really heavy 7-day period, they're not going to like the Paragard. You take somebody who has a 3-day period, a 4-day period, maybe they have a day or two that's heavy, they're going to do fine. It's not a problem. So interestingly, I worked at a clinic that didn't have hormonal IUDs. They only had Paragard IUDs. So I inserted them left and right on a lot of people and a lot of younger women. And I was amazed at how many, and it was a Latino community. So I will not say it's, kind of your typical Caucasian folk, but it was amazing to me that how many people just loved their IUDs. A lot of people love the Paragard IUD because it has no hormones. And so when you get it, it's not going to cause you to gain weight. It's not going to cause you to have acne. It's not going to cause you to feel depressed. It's not going to do anything. It just sits there, right? It doesn't cause any hormonal changes at all. So that is a big plus factor for people.
Dr. Matyac,
Yes.
did it have counterindications? Like, I know that we went over those, but like those were for oral contraceptives mainly, right? Because there's no hormones, like you can give it to someone with coronary artery disease, or is that a no?
So we're going to get into estrogen therapy a little bit, but estrogen, one of the things about estrogen therapy is estrogen is what's causing the issues. Estrogen is increasing the risk for an embolus. And so when you use progesterone only, you are not increasing that risk.
The copper, because it's no hormones, it's fine.
The copper, because it's no hormones, is fine, but also progesterone options are also fine.
Okay, thank you.
I will tell you, the other day I was talking to a colleague of mine, a couple months ago, and she was kind of up in arms because some hematologist, I think, the patient had a DVT or a PE or something. She was young, she was in her 20s. And he was very adamant that she had to get her IUD removed. And we researched it because we were like, what is he talking about? And there used to be some indication, or I don't want to say indication, recommendation to stop progesterone only pills or progesterone therapy, but there is no more. So we couldn't find any contraindications. We removed it because it was what the hematologist recommended. The patient trusted him. Again, we want to make sure that we have good trust with everyone. She also happened to be young, and there were other potential options. She could use I think she ended up not using anything for a while, but all right. So
Dr. Matyac, just one question. Doesn't it IUD cause yeast infection? A lot of people say that and they don't go through that.
No.
Because of the yeast infection.
No, not at all. There's nothing, it is, when it's inserted, there is a very small risk of infection because you're putting a foreign body through, and like I said, nothing is sterile, right? We're in the outpatient setting. You clean with betadine, but we're not letting the betadine dry completely. We can't clean the entire vaginal area with the betadine, but you clean around the cervix with the betadine. You do a good job, you do your best. Hopefully there's no infection that you're introducing, but it is possible. Once it's inserted, or as you're inserting, there is a small risk for penetration of the uterine wall. That can cause issues, although it typically causes bleeding and pain. Once the IUD is removed, it's fine. Occasionally the patient doesn't notice and it gets embedded in the uterine wall. That can cause problems. However, that's it. It does not cause any infection. When a provider cuts the strings too short, they're kind of plasticky strings. And so if you cut them too short, they're short and pokey. And so during intercourse, a male can feel the pokiness. I do think that if the partner is complaining of that, you can put in another one, or they may want it removed because they don't want it to happen again. But they need to understand it's because the provider cut it too short. So I typically cut too long. And when they come in for a 1 month checkup, I check out their strings and I will trim them more if they're still really long. But the IUD takes a little bit to get it placed into the right spot in the uterus. Sometimes it'll migrate up a little bit or down a little bit once you after you insert it. So it is nothing other than plastic. Like there's nothing to cause a yeast infection. I will say, Yasmin, I am a believer in my patients. And I will say that there are things that they say to me that have no explanation whatsoever. And I think it sounds totally quacky. And if they are firm believers that this is happening, then maybe they have like a sensitivity to the plastic that was used. The likelihood of that is way low. However, if they're convinced of this, for the most part, I will accommodate them. I have a harder time accommodating someone who wants an IUD out in the first year, because I feel like they just need to get their body accustomed and just kind of be patient with it. The other thing is that you have to remember that when you put an IUD, that sucker's expensive. And so I don't want to take it out and then 2 months later them say, oh, I'm still getting yeast infections. Can you put that in again? Like, I want to be prudent, financially prudent with what we're doing with our healthcare dollars. All right. Estrogen therapy is not used unopposed in contraceptive therapy. And Dr. Lancaster next week, we'll talk a little bit about perimenopausal and postmenopausal symptoms. But essentially, anybody who has an intact uterus should not have unopposed estrogen. There's a risk of endometrial cancer, and we want to prevent that. So you need the estrogen with progesterone. If there is no uterus, if they've had a hysterectomy, then there's no reason for the progesterone, and you don't have to use it. All right. There is a slight increased risk for endometrial cancer. We'll talk about that in a minute. Increased risk for coronary heart disease, and with combination with hormone replacement therapy, which again, Dr. Lancaster will talk about more next week. We talked about that. Talked about DVTs. If someone has a stroke or MI in the last year, please do not give them any estrogen. That would just be a bad idea. I think of that more for your elderly patients. However, I have a patient who had she had a stroke, but she also had an MI. And I want to say she was like 35. I mean, she was super young. I'm not sure where it happened. So here's our risk factors. We really want to think about our risk factors when we're prescribing anything with estrogen in it. This being for menopausal, postmenopausal women or perimenopausal women, and women of childbearing age. So if I have someone come into me who's a smoker and overweight with high blood pressure, I'm going to steer them somewhere else. Remember, as you establish a relationship with your patients, you do get to influence their decisions a lot. A lot of people will come in and say, well, what do you think? And I'm like, oh, I don't know. I mean, if it was me, this is what I would do, but I don't know what you want. But it takes a lot for me to give into that, if you will. Again, just a reminder of what estrogen can do. And then look at your risks for being a smoker. This is under age 35. This is over age 35. Look at this. With the likelihood of having some kind of receiving mortality with smoking and contraceptive is crazy high. All right. We usually use estrogen and progesterone. That's how all our COCs are. We talked about that. All right. This is a bunch of different kinds of estrogen. Take note of all of them. You will see them all. There's some that you'll see less than others. Crenone I don't see very often. ProChief I don't see often, but a lot of these I see very, very regularly. All right, and then these are androgen-derived progestins. So things that you want to be familiar with. And just the spironolactone is progesterone developed as a derivative of the spironolactone. I'm sorry, the desperadone. We talked about IUDs a little already. Okay, this is total untrue. So when there's I'm going to call it a theory that when someone is on their menses, that the cervix, that muscle relaxes a little bit and is a little bit more open. And so inserting an IUD when someone is on their period is helpful. I will tell you, I can't attest to that one way or another because I absolutely positively just do it whenever the patient wants it. I don't want to do that. Natural childbirth is required to use an IUD. Not true. It is extremely effective without using hormones. The copper one is. It is ideal. Must is an overstatement. It's ideal to be in a monogamous relationship. Okay. So make sure you note those untrue items on there. Okay, precautions and contraindications. We still want to be careful with thromboembolic disease, even though there's no good data there. Breast cancer, we talked about the impaired liver function. It can cause depression. People who have a history of severe depression may not be the best candidates for progesterone therapy. Disorders that worsen with fluid retention, because it can cause some fluid retention. Progesterone is not ideal in pregnancy. However, there's not really good data that says this is what happened to my baby because I didn't know I was pregnant and I didn't get off birth control. People who stop their birth control or have an IUD removed or whatever, when they find out they're pregnant, that is not typically an issue. So you don't want to give it, but you don't stress about it either. Adverse drug reactions that unfortunately occur with progesterone, and you're going to see it is irregular bleeding, but it can also stop irregular bleeding. It can cause amenorrhea. It can cause acne, although I don't feel like that's a common side effect. The irregular bleeding or amenorrhea is more common. And then we're going to talk about with the injectable and implanted progesterone weight gain, although less so with the injectable. I'm sorry, more so with the injectable compared to the implanted. Irregular menstrual bleeding, we'll talk about that a little bit more. And then there is a risk of osteoporosis with 2 or more years of use. That's specifically with the injectable more than it doesn't apply to the implanted. However, after 1 year of abstinence from using the injectable progesterone, your risk of osteoporosis returns to normal. So even if somebody wants to be on this for 4 or 6 years, what we found is that as soon as they stop it, it goes back to normal. So do I want to use a Depo-Provera in someone who is like between 30 and 40? Probably not, because at 40, we may already notice some differences in their bone, in their bones, and they're not whatever normal is. I don't know if they're going to bounce back to what normal was, right? But if they're in their 20s, I'm not worried about their bones at all. So like using it from 20 to 30 or from 16 to 30, I think that they're going to bounce back. And there's pretty good data from that. I think that I have a picture of that as well. We talked about the progesterone only pills that are, they stop ovulation about 50% of the time. The medroxyprogesterone is your Depo-Provera injectable. There's 2 different doses of that. We'll get to that in a moment. Then there's the progestin implanted intrauterine device. There's a number of those now. I think we are up to 4 of them. For some reason, I thought there were 5, but I was not finding it when I was looking for it. And then postmenopausal hormone replacement, which we won't talk about today. So the Mirena and Kyleena are indicated, they're the progesterone IUDs, they're indicated for 5 years. Mirena has data for up to 7 years, and it might be able to be used longer, like up to 10 years. There's not It's very interesting. Like 2 years ago, I was at a conference and one of the folks from Morena was there, and she said, it's supposed to be coming out next week, that they got their extension to 7 years. And I have been watching for it. And I see it in, like if you look up paperwork, like discharge paperwork summaries for people who have IUD placements, some places, I think like Planned Parenthood puts it in there that it's 7 years. However, if you look on Up to Date and get our very non-biased information, it still says like that's off-label use, I guess, to keep it until 7 years. However, speaking with some GYN folks, Mirena, pretty much if you're not having your period, then your Mirena or your Kyleena is working just fine. Mirena has just been around a little bit longer than Kyleena. They've also come up with Liletta and Skyla. And so those are good. I'm sorry, I didn't put it in here. It's good for 3 years. Again, I think Liletta is the one that has approval now till 4 years, but they may be able to be used till 5 years. This is kind of a work in progress. And let me tell you, it's been in progress for 5+ years that we've been working on collecting data on this. I don't want to say food for thought, something to remember, something to kind of put a key note on, that when you're inserting an IUD, the way you insert a copper IUD, it goes to the fundus of the uterus and you discharge it at that point. When you put in a progesterone IUD, I want to kill these manufacturers because each one has a different discharge device, which drives me nuts because I get in there and I'm ready to put in my IUD and I feel kind of dumb that I don't know how to do it because I forgot which device I'm using. The Mirena, well, I think all of these, it's fair to say, unlike with the copper IUD, when you're using a hormonal IUD, instead of putting it all the way up to the fundus and keeping it there while you discharge, you need to pull back just slightly before you release. Okay, that said, the device is about this big. Usually before I put them in, I sound the uterus to see how deep it is. When you sound the uterus, like maybe I have a 5 centimeter deep uterus, right? So maybe 5 centimeters. I'm putting this maybe 3 centimeter thing in here. I got to be real. That isn't a lot of playroom, right? You have to be really careful because you can pull the IUD right out when you pull out your device to place it.
Dr. Matyac.
Yes.
When you talk about like 5 years and 7 years, so if the patient's had it in for 5 years, when they come in to remove it, can you directly put another one right in at that same visit, or do you have to? Okay.
Yes.
So, okay.
So I will tell you, I used to work somewhere else where it was, they wouldn't do it. The way, maybe it was my scheduling. Was I scheduled every 15 minutes or something like that? I don't remember. They wouldn't do it because of this time I had for scheduling. But once you're accustomed to putting in taking in an IUD, taking in an IUD takes seconds. It's fast. It's easy. Putting in an IUD should be a pretty quick procedure, unless there's something going on. And so, it's dependent somewhat on the clinic that you're working with. Here's a little bit of data for you on the 7 years. So there's lots of good data. This is about 1,000 women. This stops around 2016 now. So there's more data now, but it's a pretty good indicator that this is very effective. It's over 99% effective, hormonally IUDs are. So it's quite wonderful, a great thing to do. You put it in and you forget about it and don't worry about it. The injection, you can use the progesterone injection for endometrial treatment as well, or endometriosis treatment as well, for people who have pain. However, that's not something that I'm likely to do in the office. I'm going to send them to a specialist more likely. For contraception, you're going to use, most common is the 150 milligrams, excuse me, I put micrograms there. But there is a sub-Q one that is a little bit less medication. I know less about this. I haven't been in offices where the sub-Q one is used, but it's the same. It's every 3 months. They should receive this within 5 days of the onset of their menses to be effective. And they should be greater than 6 weeks postpartum before getting it. All right. And it's super effective. Very, very effective, which is nice. It is a large dose and it goes in the hip. And so that is not the best for some people who don't like shots. So while we're on this, before I forget, as far as the weight gain, people who are of average size or a little bit on the higher end of average size, a little on the overweight category, like BMI over 25, this is my anecdotal experience. This isn't any statistics. I find that those people are more likely to gain weight. The people who tend to be my like 18, 19, 20% as a BMI, those folks tend to do fine on this. And I don't know what it is about their metabolism, but they tend to do well. I actually started treating someone with Depo-Provera. She had a tendency to lose weight after pregnancy. She also had like 4 kids and was 28 and worked and had all kinds of other things going on. So my guess is that weight loss was likely related to really just not eating enough. But nonetheless, when she needed birth control, and we were discussing what her options were, and I was like, oh, well, maybe Depo is a good choice because maybe you'll gain some weight. And I had tried a couple other things to get her to gain weight. And sure enough, she was maintaining her weight with Depo. She didn't lose. All right, so the shot works. Same as the pill, it stops ovulations. It also stops menstrual cycle, and it also thickens cervical mucus. So this is significant. I want you to know this because when we talked about the copper IUD, but when you use the hormonal IUD, it also will cause you to have a thickened area of cervical mucus. Now, by no means is this going to prevent sexually transmitted infections. However, it does block the passage of sperm into the uterus often. It could potentially prevent a sexually transmitted infection. Nobody's going to go out and gather data on that, I don't think, because to do that, we would have to expose people, and we're not going to do that. However, just kind of food for thought. So when I was saying to you how the copper IUD works, and you don't want to give that to someone who is absolutely, pro-life and doesn't want to have any chance of any kind of aborting a potential life, then your hormonal IUDs are safe because they're preventing, they should be preventing ovulation, and they're also preventing the the passage of sperm into the uterus. So that same thing happens with the Depo-Provera. This same thing is going to happen when you use the Nexplanon. Okay. This is just information for you when to do it so that you have this information when you get your re-injection. If you get the injection missed or late, they need some kind of backup contraception. And an absence of pregnancy should be confirmed prior to the next injection. Some people, oh gosh, I'm going out of town for a week or two. Can I get it early? Yes, you can get it early. It's not awesome. It might cause, it's extra progesterone, but most people do fine with that. Ideally after 6 weeks postpartum is breastfeeding. When breastfeeding, they're not going to be ovulating at that point anyway at 6 weeks. So that shouldn't be an issue either. However, if someone has an abortion or they're not breastfeeding, then you can do it immediately after an abortion or after the birth of a child. And again, that's prudent, right? Like you want to do that. This is with the Depo-Provera, decreased bleeding over time. So so this is part of what I don't like about the Depo. There's many things I don't like about Depo. I'm totally biased. These folks here. So what is this? Like 20. So what is this? 40% of folks have some kind of bleeding or spotting in the first 3 months. There are over 20% who have amenorrhea. They don't have a period at all. which most of them are delighted about. There's some that have some spotting, a considerable amount who have spotting. There are just a handful of people, less than 10%, who just bleed. They bleed every day and they hate it. That gets better if you use it for 6 months, and it gets better if you use it for 12 months. However, I have to say, as a female, I would not want to have anybody, I wouldn't want to have my period for 12 months. That's ridiculous. So weigh this when you're making decisions with your patients. Make sure that they know you do have a really good chance of your period stopping altogether, but it's more likely that you're going to have a little bit of spotting, or you might even have a good chance that you might have some bleeding, right? People need to know this. They need to be aware. They also need to be aware that that's normal. That's okay. I'm not watching my time. Oh, good. Okay. Do you guys need a 5 or 10 minute break?
Yes.
Yes. Okay. Go for it.
Is it okay if I ask some questions?
Of course. Oh, and I don't have my chat box open, so there might be lots of questions.
Oh yeah, there are. This is piggybacking off of those.
Okay. Well, why don't you go for it? I'd rather hear it than try to read through them.
So then Natalie Robbins pointed out, like some people just, because of religious beliefs, I don't want any contraceptive at all, right? So then, alternative methods outside of that are going to be challenging. Like my wife had one coworker, this is purely anecdotal, evidence super low, where she was like OB nurse, and then she did timing. Is that even remotely feasible for patients that are Catholic, and does it work fairly well? And what is the percentage of that? I'm sure we might be getting into that. Who knows?
We will get into it. We may run out of time, so I'm going to answer your question.
Okay.
So it's very effective. There's a couple things that you are supposed to monitor. First of all, you need to know some women will have a 28-day period. Somebody watch my 5 minutes for me, will you?
Oh, sorry.
That's okay. I just don't want to get sidetracked and miss our going back to this. You should know. So I'm going to assume that a woman is going to have a 28-day cycle. That is not true of all women. Sometimes it's 30, sometimes it's 26. It's variable. But if they have a 28-day cycle, 14 days before they start their period, they should ovulate. Many women will feel ovulation. There's something they call it Mittelschmerz, and it's from a German word. It's like the middle of the cycle. There's cervical mucus thickening. Not thickening. It's stretchy. So they equate it to think of like an egg white or something like that. And you can literally, it's just very stretchy, and it doesn't break. So when someone is not able to get pregnant, we were talking about the cervical mucus thickens, and so the sperm doesn't go through. Similarly, or I guess the opposite of that is when they're potentially able to get pregnant, their most likely time to get pregnant, it's mucus, it's crazy stretchy. And so sometimes, women frequently have some vaginal discharge that's very normal. And so when they have vaginal discharge, they'll notice that, oh, that was crazy stretchy. This must be the time. If people monitor their temperature, they can monitor their temperature, and they can know when their temperature goes up just a little bit, that's when they're ovulating. Furthermore, these days, there's ovulation, just like there's pregnancy tests, there's ovulation tests. And so you can see when you're actually ovulating. Now, notably, you see when you're ovulating, sperm can be, they live for 72 hours, right? So just because the egg came this day doesn't mean, if you're trying to get pregnant, that's great. But if you're not trying to get pregnant, you're a little too late, right? But people know. And then there's actually, I forget what they're called. There's something beads, I forget the name of them. But they're beads, and they quite literally, there's removable ones, and there's, brown and kind of orangey red ones, and you take them out to make the right number of days for your cycle. And that I think there's red, white, and brown. So most of the days are brown. The white days, you cannot have intercourse because you don't want to get pregnant. And the red days are when your period should come. That can be a very effective method of birth control for a lot of people. But they have to really pay attention. They also can't leave it to the wind, right? You have to really pay attention. And the withdrawal method is super ineffective. So it depends. So it depends on what someone is using, right? But if you're really tracking, it's very possible.
There's some great apps to do that as well.
Mm-hmm.
Like online on your phone.
Yes, there are some great ones like that.
Clue is a good one, and it's free.
Mhm.
What is it?
Clue.
Clue?
It's spelled like Clue, like the game Clue, or
Yeah, I believe so. I think it's CLUE. It's
Okay.
also effective. Yeah, like the game Clue, to sit there and track to see if periods are irregular. So if somebody's like maybe not paying attention to their cycle and they want to see if they're becoming irregular as they get older, it's a good way to track to see, because I was told by somebody that you can't give a diagnosis of menopause until periods become irregular. Yeah. And that they might be having a lot of so they're perimenopausal until that starts to happen.
So I'm gonna have to correct you. I'm walking away to get water, but someone is not considered menopausal until they haven't had a menses in an entire year. When it starts to become irregular is usually when someone's considered perimenopausal.
Oh, wow.
Dr. Matyac, can I ask you a question as well about that?
Can I go get water really quick before I?
You know what, Dr. Matyac? No, you've been lectured.
I'll answer your question. I'm just joking. I'll be back in like 2 minutes.
Okay.
But yeah, like the clue one, you can you put in like how heavy your bleeding is, if you're having cramps.
And is it pretty easy to use for patients? Like if you had a patient, you know, like at all age or other levels, like they'd be able to follow pretty simply. I obviously wouldn't have too much experience there.
I think it's pretty easy to use. There's not necessarily a lot of buttons for it. Like when you're trying to track how heavy the flow is, you go down to where it says track, and then you pick up the one that looks like little blood spots, and then you pick, you know, it gives you words, but also gives you pictures. Like, you know, like really heavy is a really big blood thing, and so you can see that it means a lot of blood and things like that. And so you can go through things. You can even track if you had unprotected sex, so it can help you see what's the likelihood that you might become pregnant if you had unprotected sex around when your potential ovulation day is. And it updates regularly. Like it used to show a fertility window, but they took that out because not every female ovulates at the same thing. So they didn't want people using that app too much to try and plan a pregnancy.
Yeah, like not everyone's cycle is 28 days, but that's typically what we use as like a standard.
It actually can tell you what your average cycle time is. Like, you know, it'll tell you like if you're 29-day cycle or like a 32-day cycle based off of when you're inputting all your information in.
So Dr. Matyac?
Yeah.
A lot of my friends I've heard from people with the IUD that they're having these like crazy like inflammation symptoms, and they'll tell me things like, well, my body just hated it. It wanted it gone. It was trying to push it out. Have you had patients tell you that? And if so, like, do you just kind of say like, it's gonna suck for a while, but like maybe in 2 months it's gonna get better and you should really stick it out? Like at what point are you like, okay, no, this is an abnormal reaction to this IUD?
So that, like what you just described, I've not actually heard that, but I have heard lots of kind of weird things that people tell me, just like the yeast infection thing that I think Sylvia said earlier. I really try to believe my patients, and I also try to use data to say, while it's possible, it's very unlikely, and let's see how let's just give it a couple more months. Or I might tell someone, you know, if they're at 1 or 2 months, I might say, let's see how you do at like 6 or 7 months. And if it's still like this, then we can take it out. If they've made it to 6 months, I'll say, you know what, some people have a hard time in the first year. Let's wait for a year to pass. And if you're still having these issues at a year, then let's take it out. Or some people will swear to me that it's causing their hip pain or whatever. And so I really encourage people to keep it in. Again, it's in the interest of them in contraception, but also in the financial interest of the healthcare system, that if it doesn't make sense to me, then it doesn't. Like a friend of mine recently told me, she's like, I think that this IUD is making my thighs get big. And I'm like, no, probably not. I mean, maybe you gain some weight and it can affect your appetite and it can cause some weight gain, but
pandemic.
I mean, was it injected in the thigh? Because you said there's one that get
No,
injected in the hip.
this is the IUD. This is the IUD.
And this is coming from older people who are very natural, and like my friend is hippie, and so they're saying like, well, my body recognized it as a foreign object, and so I'm having this like massive immune response against it. But that doesn't really make sense to me. And I don't.
It doesn't. Okay, so Kelsey, I'm going to go a little off to my personal beliefs. And it's not completely personal. There's data behind some of this. But I had a neighbor who, beyond what I knew, she educated me further. And she had, this is just my example. She has rheumatoid arthritis, and she ate this incredibly restricted diet. I mean, like 5 different foods. That was it for a long time. And that's the best she felt, because she ate these 5. I'm not joking.
Yeah.
I'm not, like no ginger, no garlic, no, like just these 5 foods. It was insane. And she'd gradually increase or decrease or whatever, and avoid nightshades, which do cause inflammation. We know that nightshade vegetables do cause inflammation. But she would follow this really, really strict diet. Well, she was having all these issues, and she had, I don't even know what the rationale was behind it, but she got her fillings removed. She had silver fillings.
Mm-hmm.
And her life almost returned to normal.
Huh.
So, and there's data that says there's a little tiny bit of mercury or something in there, and it can possibly cause irritation. So is your friend really experiencing this? I don't know, but you know what? Everybody's body is different, and it's not natural. And I'm not here to say that you can't have some kind of weird reaction, right? Like some people really have, they have odd reactions to like water. Well, it's not the water itself, it's the chemicals in the water that they're reacting to most likely, right? But when they take a shower, they get hives, or, like same thing, people who go out into sunshine, sometimes they get a rash when they go out in the sun. Those are very unusual things, but you know what, they happen. And so, and my beliefs aren't way off the hook, but I do believe what people tell me. I don't tend to feel like people are making stuff up.
Yeah.
I might push it a little bit.
Yeah, but you just say like, hey, I believe you that your body's doing this, but if you don't get on some sort of birth control, here's the risk. And that's how you deal with that kind of thing.
Yes. And and again, it depends on what kind of birth control. Like if they decided on the IUD, let's try to go with the IUD. And if you're not handling that after a year, fine. If it's the depot and you don't like it, we don't have to do it again. The next one on, I'm going to try to get through 9 months or a year, something like that.
Yeah.
And some people, I did have a woman who, she had the next one on, and she felt like she'd gained a ton of weight. I took it off, and she lost like 10 pounds. And so it really was causing her weight gain. And 10 pounds is a pretty significant amount of weight. So,
What are the biological consequences of like switching back and forth between these different types with any kind of frequency or?
Nothing.
Nothing.
It might whack out your period for a little bit. But the long-term data on any birth control is that your period will go back to your potential to get pregnant goes back to normal. And so there's, I was in Tanzania, ironically, when I was pregnant, but I was doing some like education of some folks who, they actually lived in town as nannies, but their families were out in the bush. And so we talked a lot about contraception and what it will do, because they were under the impression that if they took the pill or if they did whatever, that they would never be able to have kids. And although they were in their 20s and they didn't want to get pregnant, they wanted to have kids someday. And so they were really worried about it. And so it was helpful to dispel these myths that, you couldn't get pregnant. So, all right, so I'm gonna get back to lecture. I suspect we're not gonna get through this lecture. I will tell you, I went over some of the most important stuff at the beginning. We'll see how far we go. Anyway, I think we're still on the depot is where we were. Irregular periods for 3 to 6 months, and typically no periods after that, but depends on the person. You just saw the stats. Weight change is very common. Breast tenderness is common. Mood changes. That can happen with the IUD and the Nexplanon as well, but not every woman has side effects. And so I don't want you to, I think I try to start conversations with, well, not everyone actually has side effects, but when you do, these are the things that are likely to happen. Oh, this slide got kind of funky. Sorry. Oh, this was the bone density one. So this is when people were using the depot over, this is 3 years. And then when they stopped it, their bone density went right back to normal. So just be aware of that. Oh, is this the cumulative contraception months after? Oh, I'm sorry. This is the one that talks about how likely someone is to get pregnant after they stop the depot. And so it's about, I would say 10 to 15 months or even 20 months before their periods go, like they are as likely as non-hormonal contraceptive users to be able to resume their ability to get pregnant. So it does take time to be able to get pregnant after using the depot. We've kind of talked about these. It's a very simple, it's very simple to put the Implanon in, or the Nexplanon in. It's not very simple to get it out. It's just like it is like a paper matchstick about yay long, 2 inches or so. Very effective. It's wonderful. I have a picture here. This is the Norplant. I don't know if anybody even remembers Norplant, that we do not use 5 of these suckers anymore. Thank goodness, because they're a pain in the butt. They changed the guidelines in 2018 as to where you can put it. So I really love this picture here. It's a cross-sectional picture. And so what was happening is that the median nerve is here and the brachial artery was here, and people were not paying attention to where they were putting it. Actually, I believe that I learned how to use it after this. So I'm not sure how it was, but I'm pretty sure you put it in the sulcus is where we were told to put it in. And they were having too many issues. And so they looked at the structure. And so no longer are you supposed to put it in the sulcus, but you're supposed to do, so about 8 to 10 centimeters from the elbow, and then 3 to 5 centimeters below the sulcus, so that you're not getting the vessels or the nerves. And so it's less of an issue. With Nexplanon, With Nexplanon, just know you can put in a hormone, an IUD with just training in clinic. You'll learn to do it in your procedures class. However, with Nexplanon, because they have had so many issues over the years, Nexplanon requires that you have official training prior to being certified to be able to put it in. So I did not, the clinic that I previously worked at in Colorado, we didn't use Nexplanon, so I never put it in. I never got the training. After I moved here, when I had the opportunity, I finally went and got my training, because my patients would come in and they'd want it put in or taken out or whatever, and I was unable to do it. So it got frustrating. All right. Implants good for 3 years. There's no upkeep. It's very effective. It's a great method of birth control. The things that I don't like about it is the days of spotting. So a lot of people have a lot of spotting with this, unfortunately. And you can see here, so a lot of people are having amenorrhea or no menses, but a lot of people are having spotting with this as well, with the Implanon. I do want to cover this a little bit. So when some people have irregular menses, secondary amenorrhea, which is amenorrhea with a secondary cause. There's something that's causing the amenorrhea. And more often I treat abnormal uterine bleeding, so persistent heavy menorrhagia or metrorrhagia. I treat with Provera or Igestin. It is high dose progesterone that you give usually for 7 days. And then when you stop it abruptly, and the body will often have a period during that time, but when you stop it abruptly, then you have a heavy bleed and then it's over. So people who are having really heavy bleeding this is a way to get that to stop that bleeding. And it'll often last for a few months. It depends on the person. And some people, I'm trying to remember, I had a patient who had the worst menses, and she was in her like mid 40s or something, but I think she was uninsured. And so she was not in a good spot. Like couldn't do, I'm sure she had endometriosis, but she'd always been like that. And she was used to it. And she used iron because she'd had anemia, and she didn't want surgery. So it was what it was. But it was really hard to watch her be in her mid 40s and just bleeding all the time. Anyway, with endometriosis, it is something that you can treat on a regular dose, daily dosing. But that is something, again, that's not something that I would treat in the office. Progesterone-only pills, I feel like I covered those pretty sufficiently. Injectable, this is where I got a little out of order, sorry. Okay, oral contraceptives, they're all pretty similar in effectiveness. Something that you need to know. I don't know. There's generics that are pretty cheap at this point. Insurance really is dictating what is covered. And I remember going to, well, actually, it wasn't me. It was a friend of mine, but she went to Kaiser. She changed, and she was so mad because she had used this one brand of pill forever, and they gave her the generic of that brand, and it was slightly different. And she was just irate about it because it wasn't what she was used to. And I don't remember if it caused side effects or not, but they're often very similar. All right. Okay. So the non-contraceptive benefits from contraceptives are huge. So not the copper IUD, but all the other treatments, the progesterone treatments can be helpful for stopping menses. So think about someone with spotting all month long, or who has their period for 2 solid weeks each month, or 2 solid weeks and then a week break and another 2 weeks, some just weird stuff. People who have, so anyway, the progesterones are good for those. Combined oral contraceptives, COCs, can, and the patch and ring can cause or help the same way. It will regulate the menses. People who have menstrual migraines, you stop the menses. So an IUD can stop the menses. Continuous oral contraceptives can stop your menses so that they're not getting that, or severe premenstrual syndrome. I totally don't disagree with. Oh goodness, it wasn't you, Kelsey, who said, Natalie, who said that you could use SSRIs for treatment of PMDD. However, not having your period is very effective as well. And so things to think about, some people who have ovarian cysts, the combined oral contraceptives will actually shrink the estrogen, I believe it is, will shrink the cysts so that they're not painful. Some cysts will burst and it'll cause discomfort to the patient if it's happening over and over. So oral contraceptives are amazing. They are, depending on the patient, progesterone isn't particularly great can cause acne, but combined oral contraceptives can decrease acne. It's often used as an acne treatment. So people who have really heavy cramping with their menses, that's a great treatment, is to use any of these contraceptives that control your menses. It reduces your endometrial and ovarian cancer risk. Lowering the incidence of benign breast conditions like fibrocystic changes. I mean, there's just the benefits of taking contraceptives is pretty outstanding. And it's used for a ton of things. Now, I said all those things. People with migraines that are not menstrual or not, I suppose, it could make them worse as well. It could make someone with acne, it could make their acne worse. It might take care of their acne, it might make it go away, but it also could make it worse. So when you're looking at the patient, look at the whole picture. Look at, when you're doing your well child checks and you send mom or dad out of the room and down the hall, and we talk about, what's going on and how's your period, and have you thought about being sexually active, or are you sexually active? Oh, and you're worried about your acne. Oh, and look, it's on your back. So you can't, like, a topical cream for your face isn't going to do the trick. What about, how would you feel about using the pill? It's probably going to help the acne on your back, a little bit of protection if she's thinking about having sex. So it's multifaceted. And that often helps teenagers if they're in a position where they're going to be sexually active. It helps them make decisions about that. Or people who have, bad cramping or bad premenstrual disorder. It can be very helpful. We talked about the potentially preventing sexually transmitted infections. Again, I'm not gonna tout that. I'm not trying to tout any studies, but it is possible. I'm not going to tell my patients that, honestly. And people who have endometriosis, it can help with the endometriosis, especially if they don't want pregnancy. The hormones and pregnancy can actually make endometriosis get worse, and so suppressing their menses can sometimes help. I guess these are things that we should be aware of. It can increase your cholesterol. There's interactions with certain medications. I don't see on here specifically with anything that involves the estrogen or combined oral contraceptives. You need to be careful with using antibiotics. I tell people to use a backup method while they're taking the antibiotics and for the week following taking antibiotics. All right. And then we talked about this before. I feel like it stops the ovulation and also thins uterine lining. So people are less likely to have heavy menses when they have menses. I feel like we talked about this as well. Sorry, I'm just trying to get through this as much as we can. Okay, this I think is an important slide. So when you're starting something like that, some kind of combined oral contraceptive, you can start it any time. Absolutely, you can start it today. As a matter of fact, if you're going to go home and you've been having unprotected sex every day, and I'm really worried about you, go home and start it now. Please use condoms for the first 7 to 14 days. However, and I say 7 to 14 days, 7 days is usually okay. However, I'd rather say 14 because maybe they'll do it for 7 and not 6 or 5 or 4. So I usually say 7 to 14 days to use condoms, but you can start any day. The question about whether or not you can start if it was this Sunday or next Sunday, the first day of your period, start your pills. It will then keep you pretty consistent with your periods if you're taking the 3 weeks of pills and having 1 week of blanks or no pills. If someone has an abortion, they want to take them immediately post-abortion, or if you're doing like a emergency contraceptive immediately after that, because you do want to prevent a future pregnancy. And then these are actually, interestingly, oral contraceptives are used in women who don't have regular menses, like people who have PCOS. You can use oral contraceptives for 2 to 3 months to actually regulate their menses. And the first month that they stop the pills, they are the most fertile. And so it's actually used for people with PCOS to help them get pregnant. Even though it's 3 months of taking birth control, they're more likely to get pregnant in that first month that they're off. So I would use that not infrequently with my folks who couldn't afford going to a contraceptive specialist. Obviously, we want to get a medical history and physical examination. We talked about that. You want to talk about all those risk factors, those that we talked about, the 4 different classes that people fall in, if their risk classes. And then we need to talk about, like, can they do this? I had another friend who in college, she would set her alarm clock for 5 o'clock every morning because she knew every morning at 5 o'clock she would be in her bed, and she took her pill every day, and then she'd go back to bed. But she wanted to take that pill every day at the absolute same time, and she did, which was very effective, right? That's the best way to take these. Typically, if somebody misses 1 pill, it's okay, but if they're missing more than 1 pill, they really need to use some backup. All right, we talked about this. I think we've talked about that. I feel like we've talked about this to some extent. I did want to point this out with this one, with your duration of oral contraceptive use, and that's combined oral contraceptive use, your chances of ovarian and endometrial cancer actually go down over time. Your risk of breast cancer remains neutral. It is also protective against colon cancer, which is interesting. All All right. There's not been awesome data about oral contraceptives and the increased risk of breast cancer. I talked to the patients about it. There's a slightly increased risk in current use of oral contraceptives who stopped taking them in less than 10 years ago for people who had who got breast cancer, I believe. But after 10 years, so I guess what I'm getting at is women who are younger are less likely to get breast cancer. So if they haven't used any oral contraceptives in the last 10 years, which is those 60, 70, 80, whatever year olds, right? They're not very likely to get breast cancer secondary to oral contraceptives. They have a slightly increased, if they got maybe breast cancer at 50, that may be more likely related to the use of oral contraceptives. Same time every day, condom, this is for the first month, good luck. Use condoms when on antibiotics and the week after. If you miss, it's more than one pill, like any more than one pill. And although it may provide some protection against STDs, you tell your patients it provides no protection against STDs because it's not enough. And you think about, like, when I say STDs or STIs, I usually call them in the slides, it has to be D. I'm talking about gonorrhea, chlamydia, because HPV has nothing to do with even with condoms. HPV is hard to prevent. And HPV, the way it's spread is exposure to the virus, which is somewhere on the body. It's not necessarily, it's not bacteria that's, kind of climbing up into the genitourinary system. Similarly, HIV comes from the tears of skin. So it's not going to make a difference for something like HIV. HSV is similar to HPV. It has, it's being exposed at all to that virus. And so, again, condoms are not even terribly effective depending on where the lesion is. So condoms are the best way to go. And when people are willing to do both, that is wonderful. By the way, I have a wonderful story for those of you who don't remember, for you to tell young gentlemen when they are considering being sexually active. And I don't know how many of you remember this, but it happened in the Northeast US. I don't exactly remember where, but there were a gaggle of girls, high school girls, who all wanted to get pregnant. And so they all had short-term relationships with men. I think most of them are actually men and not their peers. And they all got pregnant. So I tell people that, I know that, no matter how much you trust them, you don't want to leave us in their hands. Please make sure you're using condoms, because you can't rely on, you don't know that she's taking that pill every single day like she should, or you don't know that she actually has the IUD that she says she has, or, you just don't know. And so it's better to be safe than sorry. But I use that as the example of the gaggle of girls who wanted to get pregnant and intentionally got pregnant, and just said that they were using birth control. All right, so there's a traditional use of oral contraceptives. So as I believe it was Kelsey was saying earlier, a lot of people do believe in, or maybe it was someone else, sorry, and that cleansing of the body. And so that the blood in the uterus builds up and that there's a discharge, and it's kind of the cleansing of the uterus. When you are using pills, you don't have that same buildup. It's not necessary. If you have enough buildup, you will bleed. You'll have breakthrough bleeding. However, if people really believe in that and they want to use the combined COCs, then having using the pill 21 days and having the period inactive tablets or no tablets for 1 week is fine to have a withdrawal bleed. The reason, so they have this extended cycle of 84 days of the drug, which is 3 months, and then 7 days off. There's like seasonal, there's a couple of them. I think they were in a prior picture. Otherwise, they're in another future picture. Anyway, that's a great way to go. Similarly, you just have a withdrawal bleed. Often having a withdrawal bleed will prevent spotting if someone is having spotting. However, if they're not having spotting, and let's say they have menstrual migraines or something like that, that are really disabling, or premenstrual disorder or something like that, then there's no reason they actually have to have a period. So if they want to take the pill, I tell them, you know, you could have your period like once a year, you know, it doesn't really, there's no pain, there's no problem with it. There's no, if they don't want to have their period and they want to take these continually year round, that is just fine. And we talked about the triphasic versus monophasic, and that I think that generally staying at the same dose is the best way to go. So pills typically start on the first day of the menstrual cycle. If you do that, there's no backup needed. If you do the Sunday start the following Sunday, then you need backup method for the first 7 days, because in your 28-day cycle, right, you have a period that starts, and then about 14 days later, you have ovulation. So theoretically, a period lasts 7 days, 7 more days. Well, if that 7 days, when they start on the Sunday after, they're gonna, if they have sex, then they have that 72-hour period that the sperm live. And so if they ovulate at the end of that, they're still gonna get pregnant. So with the Sunday following their start of their period, you want them to use that backup method, because you don't want them to get pregnant. And we have said Sunday start for all of time. However, what I really tell my patients at this point, and I mostly start them whenever they want to, there will be less breakthrough bleeding if they start with their period. However, I tell them, you know, as long as you remember the day, it doesn't matter. The only reason we say Sunday is because we remember Sunday. But if it's Monday and you remember Monday, and if it's Wednesday and you remember Wednesday, that's fine. And for any of you who have used pills or seen pills, they often have like the Monday, Tuesday, Wednesday. So you line it up with the day that you're taking it anyway. So it shouldn't be a problem. We just talked about the same day start and backup method for the first 7 to 14 days, 7 being the primo time. Sorry, I'm not. We're doing pretty good. Okay. Doses are missed and side effects. So, a lot of women start these because of the side effects of them. People can get nausea with this. They can have weight gain, irregular menses, spotting, breakthrough bleeding, breast tenderness. For some women, it really feels like getting pregnant because of the increase in the hormones. And for some people, it's really uncomfortable. Other people do great on it. So the Ortho Ever patch is different than the pills, in the sense that you cannot go consistently without a break from the patch. The dosage of estrogen in the patch requires that you take that week off. The dose is too high otherwise. So 3 weeks on, 1 week off. So change your patch every Sunday, and then 1 week off. Similarly, you want to start on the first day of the menses. Or if you do another day, then you just want to make sure that you're using a backup method for 7 to 14 days. Similar adverse reactions and the severe adverse reactions is what I'm thinking of, like your risk of having an embolism and things, which I don't care who my patient is. Please always, 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 you have to tell them that they have a risk of a potential DVT. And I just, you know, I'm giving this to you, and that might actually be like the big counseling that I give them, to just be aware of that. Okay. Increased failure rate in women weighing more than 198. I have read 150. I've seen 150. I've seen 175. So just being aware of this, and telling people that, you know, when you weigh more, it might be more likely to fail.
Is that because the increase in subcutaneous fat? And
Yes,
okay,
absolutely.
So is it more based on like obesity rather than like weight? Like someone who's like just an outlier 6'2"
Yes.
basketball player, they're probably fine. But like you know, someone on the outside, like
I believe that is true, especially since the average woman is not 6'2" and 200 pounds. But I don't know that that's the case. I suspect it's because of the subcutaneous fat. But I don't know that. And I don't know that studies really looked at that. All right, let's talk to you a little bit about it. Compliance is enhanced. I had a slew of girls when when I was first working, my first couple of years working, there were like a slew of girls who were it was in Tenino, and they were, you know, teenagers in high school, and they loved the patch. I had more girls come into me and want the patch. After that, not so many. If the patch is removed for over 24 hours, you need to back up for 7 days. And so really that they should take off a patch, put on a new one. And on that note, you can put the patch all over. So it does not have to be just right around the uterus. It can be on the torso. You don't want to put it on the upper outer arm is okay. You don't want to put it down the arm just because the blood, I think it's too far away from the body. You do want to make sure, this sounds kind of funny, but any medication that's patch based, you want to make sure that that area is warm enough to be releasing the medication. So if someone is like, they get cold on their upper back easily, and they don't typically wear sweaters or whatever, then that the medication is not going to release as well. And that is, I'm sorry, I don't know if you can hear my chickens in the background.
Dr. Matyac,
Yes.
is that patch still used? I see Sylvia saying something about it down there chatting, saying like she was told to remove it immediately. Is this still being used at the moment?
I don't, so if it was, I don't know that it was discontinued. I haven't found anything about that, but it's been in use for like 20 years. So I kind of doubt it, but I don't know. I would have to look into that.
Well, this happened like 10 years ago. So if it's still around, then it's still around. So,
Yep,
but
it's
I'm
still around.
shocked because my physician was very adamant about take it off immediately.
So this is, well, this does have estrogen in it. So the things that I can think of, the reasons that they would tell you that is a bad experience with another patient, some kind of FDA warning that came out at that time about it. That was like a short-lived thing about some kind of manufacturing issue. If you have any risk factors and they realized you had risk factors, and then in that case, I want to say take risk factors with a grain of salt. Was it a family history of breast cancer or a family history of cardiovascular disease? Like, that's not reason not to use it, but that might be enough reason for a clinician to freak out about it, right? I don't know if that makes sense. So it's different people, like just like the gentleman who said, the hematologist who told this woman to stop she had to have her Mirena IUD removed because he was afraid of clots, even though it has no known impact. So I don't know what the provider's rationale was, but we do indeed still use the patch. The patch, it does want to stay out. You do want it on for a full week. So they can't be like my 10-year-old children who like to pick Band-Aids off as soon as they put them on. And having a clean, dry area to put it on, no lotions or anything, other skin treatments to put on underneath it. They should be able to bathe and swim as usual and not have to worry about it. But again, they can't pick at it because that will cause problems. And you have people, I think you guys probably know this, that they're pickers, right? They just can't help it. They just kind of sit there and do the picking. And that will make it come off. Similar to oral contraceptives, there might be more breast discomfort in the first 2 months, but the hormones are a little bit higher with this, and so is a little bit more likely. It can be stored at room temperature. Any patch shouldn't be cut unless the manufacturer indicates that it should. All right. And then site reactions are actually what I see most often with this. It's similar to the other. It's, less effective if people are over, I'm going to say between 150 and 200 pounds. And no protection against STDs. All right. So the breakthrough bleeding, oh my goodness gracious, my color changed. I think this is the yellow and this is the blue. My understanding, you know what, there's a note at the bottom that the breakthrough bleeding was actually higher with the contraceptive patch than with the pill. Those of you who can see the notes at the bottom can tell me if I said that right, but I'm pretty darn sure. Okay, I don't know if anybody knows about the vaginal ring. It's delightful. It's called the Nuva ring. It's about this big. I acquaint it when I'm trying to describe it to a patient. I'd talk about like the little jelly bracelets that kids used to put around their wrists and probably still do. And it is estrogen and progesterone. is placed in the vagina, left there for 3 weeks, and then you take it out and leave it out for a week. It is great for people who have breakthrough bleeding. So people who you try them on the pill and they still have breakthrough bleeding, or something else, and they still have breakthrough bleeding. The ring is, because of its location, it sits in the uterus. It's so close to the ovaries that and it's a steady level of hormones throughout the month. So it's quite effective. And the systemic exposure to the estrogen is lower as well, which is kind of nice for anyone who is concerned about possible breast cancer or whatever. Whereas there's no data, but there are still people who say, I don't want to use that because. So if you have that person who's worried about this family of breast cancer, then using the NuvaRing might be an option for them. So this is your data about breakthrough bleeding. Again, you can see that the NuvaRing is just leaps and bounds above the oral contraceptives with this, which is wonderful. It gives you an idea of the size of it. So one of my favorite things about the NuvaRing is that it's, well, other than that it's constant and you don't have to think about it for a month. The people who have breakthrough bleeding or don't want to have their periods, this is a medication that you can leave in for 4 weeks, take out and put in a new one for 4 weeks. Because a lot of people, I guess, I don't know if they have breakthrough bleeding with this, but I usually, to prevent breakthrough bleeding, will tell them, leave it in, like put it in on the 1st, take it out on the 30th of every month, or take it out on the 29th of every month. 28th, February only has 28 days. And then on the 1st, put in a new one. That way their body will have a chance to have a short bleed, and then they can go back to using it. So unlike the patch, they don't have to have a break with the ring, and it actually has enough hormones to use for a full 4 weeks, unlike the patch.
So it's one ring per use, right?
One ring per month, yes.
Okay, I thought you were gonna.
So the challenges with this is that when people bear down to have bowel movement, it may come out. When people have intercourse, it can come out. People can take it out when they have intercourse. However, because it's such a kind of I'm going to say a lower dose, if you leave it out for more than 2 hours, you're at higher risk of pregnancy. So people should really be using condoms if they're leaving it out for more than 2 hours, and they should check to make sure it's present. Now, they can use condoms when it's in. They can use it during their period. That's fine. But just making sure that it's present is good. In college, I had a friend who was like, I didn't believe her when she said this. I thought she was crazy. She's like, well, I liked the ring, but then one day I checked and it wasn't there, and I have no idea what happened to it. Like, it was just gone. I have also had people say that to me about their IUD, which still mystifies me, that they didn't notice an IUD coming out and it went all the way through their cervix and out their vagina and they didn't notice. But you know what? It's not the most sensitive area of the body. So it does happen. We know the barrier method. Condoms, we like condoms. This is perfect effectiveness rate. I'm not sure if I've ever met anyone who uses condoms perfectly, and I wouldn't bet on it. Typical effectiveness rate is about 88%. And actually, I think more recent data have it as more like in the 70s. Latex are better, but they only have the non-latex kind. And I agree. I saw a comment earlier about no lambskin, which is absolutely right. That is not particularly helpful. And then including spermicide increases the effectiveness level of the condoms. You can buy condoms with the spermicide, or you can use the spermicide separately. There's a female condom as well. And this is typically made of polyurethane. It is not awesome, but it is something that I feel like a female has a little bit more control over. It is not, because of the design, it is the typical rate of efficacy is 90 or 79%, excuse me. And this is a picture of a female condom for those of you who've not seen one. And it just goes up into the vagina. And then it just, it's a barrier. So, and then, oh yes.
The female condom? Like, is it effective at all for STDs or no, not really?
Yeah, absolutely.
Just as much as the male one is?
Yeah, I believe so. Well, I mean, I would say as effective as it is for pregnancy, right? But yeah, it's pretty effective. And it's a great option. I mean, it's a great alternative. I would say the hard thing about them is that they're hard to find. And I would say they're a little awkward, right? And so that is an issue. They make it seem very nice in this picture, but that's not, I would say it's not quite as easy as that. Hence the efficacy rate is lower. Spermicides, we already talked about that. The lubricated with naloxone 9 is a better option. Does anybody know what a diaphragm is anymore? Old school. But if you see the diaphragm is also not incredibly effective. It's typically made out of latex and it's placed out of the vagina. Let's see if I have a picture. Yes. So the diaphragm is this, it's like a little cup. As a matter of fact, it's kind of like the menstrual cups that they make now. It's very similar. I don't know what the menstrual cups are made of, but I'm kind of curious about that because diaphragms are very uncommon these days. And then there's a cervical cap, which is, you have to be measured for a cervical cap and it fits around the cervix with a suction. So you fill it with spermicidal jelly prior to use and it goes right up against the cervix. That is convenient for people because it can be left in the body for 48 hours. However, it's not awesome with this efficacy rate. And there's the cervical cap. So you should know if somebody's using a cervical cap, if they gain or lose 10, 15 pounds, that's going to change the size of their cervix and therein will cause the cervical cap to not fit as snugly over the cervix. This is a sponge. I don't know. I haven't seen a sponge maybe ever in my life. And then withdrawal, we talked a little bit about it is not terribly effective. Natural family planning is, natural family planning is, I feel like a little bit different than the fertility awareness method. I think natural family planning is based on counting the days, where fertility awareness is looking at your temperature and checking the what's it called? Stretchiness of the cervical discharge. And of course, abstinence is 100% effective. I won't say it's 100% effective. You will occasionally find someone who did not have intercourse, but their partner's penis was near the vagina. That's all that needs to happen. If there's a will, there's a way. And so if the penis is close enough to the vagina at the time of ejaculation, sperm can enter into the vagina and cause pregnancy. However, that's pretty close to having intercourse. So abstinence is complete avoidance of any kind of sexual contact like that. So here we go. Effectiveness rate is 80%, but it's very unpredictable and a wide variation. If 1 of 5 women practicing withdrawal become pregnant, and it's very difficult for a male to control when it's going to happen. So not really a great option. This is just the natural family planning, fertility awareness. I feel like we've talked about that. There we go. Perfect effectiveness rate is 91%. I do feel like that's pretty good. It's better than some condoms, honestly. The calendar rhythm method. This is kind of what I was telling you about the necklace that I've seen. That tells you kind of based on your menstruation when your ovulation was, your egg may still be present up to 72 hours, even though it's not likely. It's definitely when you're about to ovulate, it's not safe. And so people really have to pay attention to that. Emergency contraception. This is more and more available and more common. I'm sorry, I'm going to stop for a second because I want to see your questions. Oh, menstrual cups are made of silicone. I wonder if silicone would be the same. Okay. All right. Just want to make sure I was reading things. So let me close that up again. So emergency contraceptive pills, I'm sorry, this says it's most effective within 72 hours, but it can actually be taken within 5 days. So please amend your slide that it can be taken within 5 days of unprotected sex. It is less and less effective each day. However, it is still a potential. We also talked before about being able to use the IUD as well. Just FYI, going back to the IUD, if someone gets pregnant with an IUD, treatment for that is removal of the IUD. Risks associated with that are potential miscarriage or loss of the baby because of removing the IUD. However, it's more risky to leave it in and allow a pregnancy to take place with an IUD present. All right. As I said, 72 to it's like 196, I don't know, 3 to 5 days within unprotected intercourse or failure of contraceptive method. It's still, there's still issues getting this at certain pharmacies. There's still issues getting it all together. I think it's quite the challenge, unfortunately. It is the Plan B, is it levonorgestrel? Yes, levonorgestrel. And typically there's 2 different ways to take it. You can take both at once, or you can take the 2 pills 12 hours apart. So a disruptive to the egg and sperm. So who knows if this is preventing it may potentially prevent the connection between the egg and the sperm, but it may not. So I think that this is, and it can prevent ovulation as well. I don't know where this falls in terms of people who are very sensitive to keeping a pregnancy. We talked about sterilization already. I don't want to talk about that anymore. I can't believe this. I think we got through all those big slides, although I also think I'm about out of time. Oh, I am totally out of time. So the end of these slides, just to let you know real quick, is I think you guys can go over these. I think you know the answer to them now. I think we've answered all of these. The answer to the 16-year-old who doesn't want a pelvic, that's fine. I don't want her to get pregnant. That's the only one I'm not sure that we answered. I use lots of IUDs in teens. I think that's helpful. But the big thing I wanted you to see was information about the dysmenorrhea, that these are treatments. And I mentioned it throughout. So I don't think that this is particularly news, but I wanted to make sure that you were aware that this exists. And then I don't know I think that Dr. Lancaster is going to talk about erectile dysfunction. So